So question number 31 here we have, it is January and 72, so here 72-year-old woman attend an acute medicine unit with a fever 38.1 degrees Celsius, coryza, frontal headache, fatigue for the last 48 hours. Her 8-year-old grandchild, whom she mined after school, has similar symptom. So this is the most likely it's a viral illness that cause this upper respiratory tract symptoms and headache, which is the most common type of virus that can cause this. It is rhinovirus. She has nasal congestion. She had a nasal congestion, but no other physical finding. Her vital signs otherwise normal. Her white cell count normal, so white cell count is not elevated normal. CRP is 10 as well. It is mildly or slightly elevated. Renal function is normal. Her chest X-ray is her chest X-ray is clear. So chest X-ray is clear. What is your treatment plan? Comoxiclav antibiotic. I think this is wrong. There is no point to give antibiotic for this viral illness. Comoxiclav 8 hourly for rhinovirus. I think this is wrong as well. There's no point. There is no signs of bacterial component of this infection because the white cell count is normal. CRP is slightly elevated, and chest X-ray is clear. So I think it is wrong to give this patient Comoxiclav. Codeine phosphate 6 mg per os 4 hourly for tension headache, for treatment of headache just, or paracetamol 1 gram 6 hourly per os PRN for rhinovirus. I think this is the most appropriate treatment here. What is your treatment plan? I think this is the paracetamol just. It will be okay. It will relieve the symptoms, which is symptomatic treatment here for rhinovirus. So the question 32, 22-year-old woman attend the acute medical unit with acute medical unit with nausea, anorexia, and fatigue and weakness for 6 weeks. She is tanned but has not been in the sun recently. Tanned, this is indicate of hyperpigmentation. So here we have hyperpigmentation. So hyperpigmentation here, hyperpigmentation, and we have fatigue, anorexia, and nausea and weakness for 6 weeks. Her previously regular period have stopped. So here we have amenorrhea. We have amenorrhea, which is absent of menstruation. She has postural hypotension, and she has hypotension. She had low blood pressure or postural hypotension, and marked proximal muscle weakness on the exam. So which of the following glands is not functioning appropriately in this lady? So here most likely we have features of what is called Addison disease, which is adrenal failure. So the most likely it is adrenal gland. Adrenal gland failure will lead to this muscle weakness because when we have adrenal gland, the glucocorticoid will be decreased. Glucocorticoid, if it's decreased in the body, will lead to postural hypotension because of vasodilatation. It will cause proximal muscle weakness and because of proteolysis and over activation of the catabolic state because of decreasing glucocorticoid, and the patient will have nausea and anorexia and fatigue, and as well the patient will have hyperpigmentation. Hyperpigmentation because of the decreasing glucocorticosteroid will lead to activation of negative feedback, and this will lead to increase in the pro-opiomelanocorticotropin. Pro-opiomelanocorticotropin increasing this will lead to increase in the melanin stimulating hormone, MSH. Increasing melanin stimulating hormone will lead to hyperpigmentation. So most likely it is adrenal gland here. So the next question here, 22-year-old woman is diagnosed with type 1 diabetes mellitus. She is worried now she won't be able to eat the food that she likes and doesn't know how much insulin to take with her meals. You advise her to participate in the DAFNI course. He's asking about what does DAFN stand for. DAFN stand for this is it stand for do adjust for normoglycemia evaluation, well do all finger prick note early, or does adjusted for night time eating, those adjusted, I'm sorry, or those adjusted for normal eating, or those advanced for normoglycemia evaluation. This is called the most likely it's a stand for those adjusted for normal eating, for normal eating. So let's move on to the next question. So let's move on to the next question here. So the answer here is D, the previous question, and so question number 34, 77-year-old lady is on holiday from the UK when she presents to the emergency department after feeling progressively unwell over the last few days. She has been vomiting, so she had chief complaint of vomiting for 24 hours, has not passed stool in 2 days. So she had element of GI tract obstruction. She had vomiting and she didn't pass stool in the last 2 days. She has never had surgery before. She never had surgery before and gave birth to 6 children. On examination, she appears dehydrated. So we have dehydration with distended abdomen. You notice 2 centimeter lump in her right groin. So and she said that she only noticed the lump in the last month and it's only became painful this week. So here we have lump in the groin about 2 centimeter and we have distended abdomen and the patient is dehydrated. So again, the patient have element of GI tract obstruction, bowel obstruction, and the patient had lump in the groin. The most important differentiation in the lump in the groin in this lady, we have to think about the hernia, groin hernia. Type of groin hernia, it's either it might be inguinal hernia or it could be a femoral hernia. So the neck of the lump is inferior. So the neck, it's inferior, it's below and lateral to the pubic tubercle. This is very important or anatomical to differentiate the type of the hernia. It's inferior and lateral to pubic tubercle. This is keyword for femoral hernia. It's inferior and lateral. If it was superior and lateral to pubic tubercle, if it was superior, so we have to think about inguinal hernia. We have to think about inguinal hernia if it's superior. This is inferior, so we have to think about femoral hernia here. The mass is below the groin crease. This is the other as well. It is other key here. It is below the groin crease. If it is below the groin crease, it is femoral hernia. If it's above the groin crease, it is inguinal hernia. All of these are keywords in this question. There is a weak cuff impulse and it is not possible. So weak cuff impulse, this is non-reassuring sign, indicate a complicated hernia, a strangulated hernia, and it is not possible to reduce the lump. So it is irreducible with gentle pressure. It is tender, so we have tenderness on palpation. The patient is febrile 38.2 and her pulse is 106 and blood pressure is normal. So you refer her to the surgical team to operate on her that day. She is most likely to be diagnosed with what condition at the surgery. Most likely this lady, she had complicated femoral hernia and the complication she had a bowel obstruction. She had a bowel obstruction. So the most likely bowel obstruction secondary to adhesion, this is wrong. Why? Because the patient, she had no adhesions because in the history here, she has never had surgery before. So adhesions here is wrong. Bowel obstruction secondary to colorectal cancer. This is unlikely. We don't know if the patient has colorectal cancer, but the aberrant physical examination, it is consist with groin hernia or femoral hernia. Bowel obstruction secondary femoral hernia, this is, I think, the most likely answer here. The bowel obstruction secondary to inguinal hernia, this is wrong. Why? Because the mass, it is below the inguinal, below the groin crease, and it is inferior to the pubic tubercle. All of these consist more with femoral hernia, not with inguinal hernia. Bowel obstruction secondary to ovarian mass, this is wrong. If was the same question and he described that the lump was superior and lateral to the tubercle and the mass is above the groin crease, the answer is going to be bowel obstruction secondary to inguinal hernia. So the question number 35, 22-year-old woman is brought to the emergency department by ambulance, had been confused and drowsy. So here we have confusion and drowsiness alone on the street at 8:30 a.m. She is sweaty and pale. So this is very important to mention. So she had confusion and drowsiness at early morning, and she's sweaty and pale. She is wearing a MIDI alert bracelet. So which of the following your first investigation? I think we have to think straight away about hypoglycemia. And this patient, we have to think that this patient might have diabetes mellitus, type 1 diabetes mellitus. So what's first investigation you have to think? CT brain, this is wrong. CT brain, it will take time to do the CT brain. So the more simple thing to think about it is the hypoglycemia, to check the glucose by glucocheck. ECG or finger prick blood glucose measurement, and this is the most appropriate, I think, first investigation. Lumbar puncture and CSF analysis, urine analysis for ketones. I think the most appropriate is finger prick blood glucose measurement to check for hypoglycemia. So the question number 36, I am going to discuss in the next video. Just to remind you that all of the previous videos and this video, I'm going to upload them in the teachable.com, in my page in the teachable.com. So, and I will put the link for teachable.com page in the description of this YouTube video. Thanks for watching this video.